MS Rodriguez brings her 2-year-old son, Gabriel, to the ER with complaints of abdominal pain and vomiting. Upon examination, Gabriel is lethargic, has dry mucous membranes, and is unable to tolerate oral fluids. His heart rate is elevated and his blood pressure is low. The physician suspects dehydration due to gastroenteritis. What are the signs and symptoms of dehydration in a child, and what are the key differences in the management approach between mild and severe dehydration? Answer: dehydration in children can be classified into mild, moderate, and severe categories based on symptoms such as mucous membrane dryness, skin turgor, urine output, heart rate, and level of consciousness. Mild dehydration includes symptoms like a slight decrease in urine output, slightly dry mucous membranes, and normal heart rate and blood pressure. Fluid management is primarily through oral rehydration solutions, ORS. The child should drink small amounts frequently with an emphasis on rehydrating over a period of 2–4 hours. Moderate dehydration symptoms include sunken eyes, dry skin, decreased urine output, irritability, and a slightly elevated heart rate. Management involves both ORS and possibly intravenous fluids if oral rehydration is not tolerated. Severe dehydration, characterized by lethargy, very dry mucous membranes, sunken fontanelle, low blood pressure, tachycardia, and minimal to no urine output. Immediate IV fluids are required to restore hydration and stabilize the child. Fluid replacement protocols include the use of isotonic solutions such as normal saline, NS, or Ringer's lactate, administered over the first 1–2 hours, followed by maintenance therapy. What are the critical steps in the emergency management of diabetic ketoacidosis (DKA) in pediatric patients? Explain the rationale behind each step, including fluid replacement and insulin therapy. Answer: the management of diabetic ketoacidosis (DKA) in pediatric patients follows a structured approach to correct dehydration, normalize glucose levels, and address electrolyte imbalances. The critical steps include fluid resuscitation. Rationale: correcting dehydration is crucial for restoring circulatory volume and improving kidney perfusion. Initially, normal saline 0.9% is administered to expand the intravascular volume. The first phase typically involves the administration of 20 mg of isotonic saline over the first 3–6 minutes. Subsequent fluids. After the initial bolus, IV fluids should be switched to half normal saline 0.45% with 5% dextrose once the blood glucose level falls below 200 mdl to prevent rapid glucose reduction, which could lead to cerebral edema. Insulin therapy. Rationale: insulin administration is necessary to stop ketogenesis and normalize glucose levels. Initially, an IV bolus of insulin 0.1 mg is given, followed by a continuous infusion at 0.1 mg. This rate should be adjusted based on blood glucose monitoring. Electrolyte management. Rationale: correcting electrolyte imbalances, particularly potassium, is crucial as insulin administration causes a shift of potassium into the cells, leading to hypokalemia. Potassium levels should be measured frequently, and potassium should be supplemented when levels are below 5.0 mecq. Sodium bicarbonate is usually not indicated unless severe acidosis persists. pH 6.9. Monitoring. Rationale: regular monitoring of vital signs, glucose levels, pH, and electrolytes is necessary to assess the patient's response to therapy and adjust fluid, insulin, and electrolyte management accordingly. Mr. Jenkins, the father of a 7-year-old girl named Emma, arrives in the ER with a complaint that his daughter is experiencing sudden severe pain in her lower abdomen, nausea, and vomiting. On physical examination, Emma shows signs of a rigid abdomen and localized tenderness in the right lower quadrant. Given the clinical presentation, the physician suspects appendicitis. What would be the next steps in the assessment and management of suspected appendicitis in this pediatric patient, and what complications should the healthcare team be aware of? Answer: in the case of suspected appendicitis, the following steps are crucial for diagnosis and management. Clinical evaluation. Signs and symptoms: abdominal pain in the right lower quadrant, fever, nausea, and vomiting are key indicators. The McBurney's point tenderness, rebound tenderness, and guarding should be assessed. Special tests. The Rossing sign, pain in the right lower quadrant upon palpation of the left lower quadrant, and so is sign, pain with extension of the right hip, can help support the diagnosis of appendicitis. Imaging studies. An ultrasound is often the first-line imaging modality in pediatric patients to avoid radiation exposure. It can reveal an inflamed appendix, fluid collection, or abscess. In cases where the diagnosis remains unclear, a CT scan can provide additional information, though it is less frequently used in children due to radiation concerns. Surgical consultation. If appendicitis is suspected, a pediatric surgeon should be consulted urgently for appendectomy. Timely surgical intervention is crucial to avoid rupture and peritonitis. If the appendix is ruptured, preoperative antibiotics should be administered to cover gram-negative and anaerobic bacteria to prevent sepsis. Complications to watch for. Ruptured appendix. If left untreated, the appendix may rupture, leading to peritonitis, sepsis, and the formation of an abscess. Intestinal obstruction. Postoperative complications can include adhesions leading to bowel obstruction. What are the differences between hypoglycemia and hyperglycemia in pediatric patients with diabetes, and how should each be managed in the emergency setting? Answer: hypoglycemia and hyperglycemia are both common and potentially life-threatening conditions in pediatric diabetes patients. Their management requires prompt intervention. Hypoglycemia. Signs and symptoms. Symptoms include confusion, shaking, sweating, irritability, and seizures in severe cases. The blood glucose level is usually below 7 mdl. Management. The first-line treatment is the administration of 15 grams of fast-acting glucose, glucose tablets, juice, or regular soda. If the child is unable to ingest orally, IV dextrose 25% solution should be administered. Continuous monitoring of glucose levels is essential until they stabilize above 7 mdl. Hypoglycemia DKA. Signs and symptoms. Symptoms include excessive thirst, polydipsia, frequent urination, polyuria, dry skin, fatigue, fruity smelling breath, and deep rapid breathing. Cosmal respirations. The blood glucose level is usually above 200 mdl. Management involves fluid resuscitation, insulin infusion, and correction of electrolyte imbalances, especially potassium. Close monitoring is necessary to prevent rapid changes in glucose that may result in cerebral edema. How is hyponatremia treated in pediatric patients, and what are the risks of overcorrection during treatment? Answer: hyponatremia, low sodium levels in children, can be a result of various conditions such as dehydration, SIADH, or kidney failure. The treatment involves gradual correction of the sodium level to avoid central pontine myelinolysis, CPA, a serious complication that can occur due to overly rapid correction. Initial management: mild hyponatremia. Gradual correction with normal saline 0.9% or half normal saline 0.45% is usually sufficient. In cases of acute severe hyponatremia, g. sodium 120 mecl hypertonic saline 3% NaCl may be used, but it should be administered slowly and in a controlled setting. Monitoring. Sodium levels should be monitored regularly, and the rate of correction should not exceed 1,2 mecl to prevent complications. Risks of overcorrection. Rapid increases in sodium can lead to central pontine myelinolysis, CPA, a condition that causes irreversible damage to the pons in the brain, leading to neurological deficits, including paralysis and death. What are the most common causes of abdominal pain in pediatric patients, and how can these be differentiated based on the child's age? Answer: abdominal pain in children can have many causes, and the differential diagnosis depends on the child's age and accompanying symptoms. Infant 0–2 months. Common causes include gastroenteritis, colic, and intestinal obstruction. E.g. intussusception. Intussusception in particular should be suspected if the infant has sudden onset crying, vomiting, and recurrent jelly stool. Toddlers 1–4 years. Appendicitis is a concern, as well as constipation and urinary tract infections, UTIs. Appendicitis often presents with localized pain in the right lower quadrant, fever, and vomiting. School-aged children 5–10 years. Common causes include appendicitis, gastritis, and gastroenteritis. Appendicitis often presents with persistent pain in the right lower quadrant, fever, and vomiting. In managing a pediatric patient with testicular torsion, why is it important to act quickly, and what is the general time window for preserving testicular viability? Answer: testicular torsion is a surgical emergency that occurs when the spermatic cord twists, leading to reduction or complete cessation of blood flow to the affected testicle. The twisting prevents arterial blood supply, while venous return is compromised, causing ischemia and the potential for permanent damage or necrosis. Early recognition and intervention are critical to preserving testicular function and viability. The optimal window for restoring blood flow and salvaging the testicle is within 6 hours of the onset of torsion. After this time, the likelihood of irreversible testicular damage increases significantly. By 12 hours, the chances of testicle survival are substantially reduced, and the risk of losing the testicle altogether becomes much higher. Beyond this time frame, The ischemia becomes more extensive and the testicle becomes necrotic, leading to loss of function and necessitating orchiectomy removal of the testicle. When torsion is suspected, urgent surgical intervention is required. The typical treatment involves performing a scrotal exploration to manually untwist the spermatic cord. If the testicle is viable, it may be fixed in place orchidopexy to prevent future episodes. If the testicle is non-viable due to prolonged ischemia, an orchiectomy is performed. What are the primary considerations in managing hyperkalemia in pediatric patients, particularly in the emergency setting? Answer: hyperkalemia, defined as a serum potassium level greater than 5.5 meckel, is a potentially life-threatening condition, especially in pediatric patients. It can lead to cardiac arrhythmias, muscle weakness, and neurological symptoms, making prompt recognition and treatment critical. Assessment and diagnosis. The first step in managing hyperkalemia is to assess the severity and clinical impact. Severe hyperkalemia, potassium levels above 6.5 meckel, presents with more serious signs, such as arrhythmias e.g., peaked T waves on the ECG, muscle weakness, and even cardiac arrest. Mild hyperkalemia may be asymptomatic or associated with non-specific symptoms, but it still requires monitoring and intervention to prevent progression. Initial management protocols. Calcium gluconate or calcium chloride is administered as an urgent intervention. It stabilizes the myocardial cell membrane and reduces the risk of arrhythmias. This does not lower the potassium level but helps prevent life-threatening arrhythmias from occurring. Insulin and glucose are given together to drive potassium into the cells, effectively lowering the serum potassium level. Sodium bicarbonate can be administered, particularly if the patient has accompanying metabolic acidosis. It works by shifting potassium into cells and can also correct the acidosis. Base agonists like albuterol can also be used to promote the shift of potassium into cells, though this effect is usually transient. Cake-salate, sodium polystyrene sulfonate, is a resin that binds potassium in the intestines, promoting its excretion via the gastrointestinal tract. However, its effect is slow and may not be effective in acute emergencies. Dialysis is the definitive treatment in cases of severe hyperkalemia that do not respond to other interventions, particularly if there is renal failure or life-threatening arrhythmias. Continuous monitoring. Cardiac monitoring is essential to track the progression of hyperkalemia and assess for changes in the ECG or new arrhythmias. Potassium levels should be rechecked frequently to ensure that interventions are effective and to avoid overcorrection. What are the clinical signs of metabolic acidosis and how is it typically treated in pediatric patients? Answer: metabolic acidosis occurs when the body accumulates acid or loses bicarbonate, resulting in a decreased blood pH. It can be caused by various conditions such as diabetic ketoacidosis, DKA, renal failure, lactic acidosis, or toxic ingestion, e.g., aspirin or methanol. Clinical signs. Cusmore breathing is the hallmark respiratory compensatory mechanism characterized by deep, labored breathing. This occurs as the body attempts to expel excess carbon dioxide, a respiratory acid, to correct the low pH. Tachycardia and hypotension may be present due to decreased blood flow and the body's attempt to compensate for the acidosis. Lethargy, vomiting, and confusion are common neurological symptoms. In severe cases, coma may occur. Muscle weakness may result from both the acidosis and electrolyte disturbances, especially hyperkalemia. In some cases, there may be a characteristic odor to the breath, e.g., fruity breath in DKA due to acetone. Treatment. The underlying cause of the metabolic acidosis must be treated first, but several general principles guide the management. Treat the cause. In renal failure, dialysis may be necessary to correct the acidosis. For lactic acidosis, identifying and treating the underlying cause, e.g., sepsis, hypoxia, toxins, is critical. Sodium bicarbonate. In cases of severe acidosis with a EA less than 7.1, sodium bicarbonate may be used to increase the pH. However, caution is necessary because rapid correction can cause significant shifts in other electrolytes, particularly potassium, and lead to complications such as hypokalemia or alkalosis. This should be used selectively and in monitored settings. Fluid resuscitation. For many causes of metabolic acidosis, IV fluids are given to restore volume and support renal perfusion, helping to correct the acidosis. Electrolyte correction. Serum electrolytes, especially potassium and sodium, must be monitored and corrected as needed. Both hyperkalemia and hypokalemia can occur, so careful management is crucial. What are the key differences in managing acute asthma exacerbations in infants compared to older children? Answer: asthma exacerbations can present differently in infants compared to older children due to the differences in their anatomy, physiology, and ability to communicate symptoms. Presentation in infants. Infants often present with wheezing, tachypnea, grunting, and retractions, especially intercostal or subcostal retractions. They may also exhibit nasal flaring and increased work of breathing. However, coughing might not be as prominent in infants compared to older children. Management in infants. Oxygen therapy should be initiated early if the oxygen saturation falls below 92%. Nebulized medications. Base agonists e.g. albuterol and anticholinergics e.g. ipratropium bromide are frequently used. However, in infants, the dose may need to be adjusted based on weight. Corticosteroids or oromanor, prednisone or prednisolone is given early to reduce inflammation. In severe cases, IV methylprednisolone may be used. Non-invasive ventilation such as CPAP may be required if there is significant work of breathing. Older children, in contrast, older children may report chest tightness, difficulty speaking in full sentences, and a coughing that is more noticeable. They are more likely to respond to inhaler therapy, metered-dose inhalers with spacers. The need for aggressive monitoring is less than in infants, but still crucial to prevent progression to respiratory failure. Considerations for both. In both groups, monitoring for respiratory distress and hypoxia is key. Any signs of decreased air entry, cyanosis, or altered mental status require immediate escalation of care. What is the primary goal in managing a pediatric patient with sickle cell crisis, and how would you address the patient's pain management needs? Include key interventions and protocols. Answer: the primary goal in managing a pediatric patient with sickle cell crisis is to alleviate pain and prevent further complications, such as organ damage or acute chest syndrome. Key interventions include hydration. IV fluids are administered to reduce blood viscosity and improve circulation. The amount of fluid depends on the child's weight, the severity of dehydration, and clinical condition. Pain management. Pain control is essential, as sickle cell crises are often accompanied by severe pain. Management includes both opioid and non-opioid options. Opioids. Morphine or hydromorphone may be used for moderate to severe pain, with dosage adjusted based on the child's age and weight. Opioids should be carefully monitored to avoid respiratory depression. Non-opioid analgesics, acetaminophen or ibuprofen can be used for mild pain. Oxygen therapy. Administer oxygen if the patient is hypoxic, SPO 92%, to enhance tissue oxygenation. However, oxygen should not be given if the patient's hemoglobin level is normal, as it may increase sickling in normal red blood cells. Preventive measures. Long-term management involves hydroxyurea therapy to reduce the frequency of crises and appropriate vaccinations to prevent infections. Transfusion. Blood transfusion is indicated if the patient is experiencing severe symptoms such as acute chest syndrome or stroke. The goal is to reduce the proportion of sickle cells by transfusing packed red blood cells. Guidelines. According to the American Society of Hematology ASH guidelines, intravenous hydration, pain control with appropriate analgesics, and oxygen therapy should be initiated promptly. If symptoms persist or worsen, further intervention may include blood transfusions or exchange transfusion protocols. 14-year-old adolescent Sarah presents with signs of depression, expressing feelings of hopelessness and worthlessness. She has a history of self-harm and recent loss of a close family member. What should the pediatric emergency nurse do to assess her suicide risk and ensure her safety? Answer: in assessing Sarah's suicide risk, the pediatric emergency nurse should use a structured and systematic approach. Key steps include suicide risk screening, use of validated tool like the Columbia Suicide Severity Rating Scale, CSRS, to assess for risk factors including past suicidal ideation, attempts, and family history. Sarah's reported feelings of hopelessness, self-harm history, and recent loss significantly increase her suicide risk. Assessing protective factors. Determine if there are any protective factors such as strong family support, religious beliefs, or a positive connection to school or community which might reduce the likelihood of suicidal behavior. Immediate safety plan. Ensure the immediate safety of the child. This may include immediate protection, securing the environment and ensuring that dangerous objects, e.g. sharp objects, medications, are removed from her reach. Psychiatric evaluation. Sarah should be referred for a psychiatric evaluation, preferably by a child and adolescent psychiatrist, to assess the need for inpatient care. Family involvement. Involve Sarah's parents or caregivers in her care, educating them on warning signs of suicide and ensuring they are part of the safety planning process is essential. Follow-up. Ensure timely follow-up care, including outpatient psychiatric care, and continued monitoring for changes in behavior. Guidelines. The American Academy of Pediatrics recommends that all adolescents at risk of suicide should be evaluated by a mental health professional. Immediate protective measures, including monitoring and psychiatric assessment, are essential for safety. A 10-year-old patient with acute leukemia undergoes chemotherapy and develops signs of tumor lysis syndrome (TLS). What is the pathophysiology of TLS, and how should the nurse intervene to prevent complications associated with this condition? Answer: tumor lysis syndrome (TLS) occurs when a large number of tumor cells rapidly break down, releasing intracellular contents into the bloodstream, leading to metabolic disturbances. Key components include pathophysiology. Hyperkalemia. Potassium released from the lysed cells can cause life-threatening cardiac arrhythmias. Hyperphosphatemia. The release of phosphorus can combine with calcium to form insoluble complexes, leading to hypocalcemia. Hyperuricemia. The breakdown of purines leads to elevated uric acid levels, which can precipitate as urate crystals in the kidneys, causing renal damage. Hypocalcemia. Due to the binding of calcium with phosphate, which can lead to tetany and seizures. Management. Hydration. IV fluids, typically normal saline, are essential to maintain renal perfusion and prevent kidney damage from uric acid crystals. Allopurinol or rasburicase. Allopurinol inhibits uric acid production, while rasburicase accelerates the breakdown of uric acid. These are used to prevent or manage hyperuricemia. Electrolyte monitoring. Regular monitoring of serum potassium, phosphate, and calcium levels is crucial. Correct abnormalities promptly. Dialysis. In severe cases of TLS with kidney failure or life-threatening electrolyte imbalances, hemodialysis may be necessary. Guidelines. The American Society of Clinical Oncology (ASCO) guidelines recommend that high-risk patients receiving chemotherapy for hematologic malignancies be closely monitored for TLS. Prevention strategies include aggressive hydration and urate-lowering therapy. When caring for a pediatric patient experiencing an emotional meltdown in the emergency department, what verbal and nonverbal de-escalation techniques should the nurse use to reduce anxiety and prevent further escalation? Answer: de-escalation is critical in managing pediatric behavioral crises to prevent harm to the patient or others. The nurse should use both verbal and nonverbal techniques. Verbal techniques: stay calm. Use a calm, steady voice. Avoid raising your voice or speaking in a harsh tone, as this may increase anxiety. Acknowledge feelings. Validate the child's emotions. For example, I can see you're upset. Let's talk about what's going on. Set clear boundaries. Establish boundaries while offering choices. For example, you need to calm down. You can sit quietly or lie down while we talk. Non-verbal techniques. Body language. Maintain an open stance. Avoid crossing arms or fists and ensure that your posture is non-threatening. Eye contact. Ensure that eye contact is respectful but not confrontational. This conveys attentiveness and empathy. Physical proximity. Maintain a safe physical distance to avoid making the child feel cornered or threatened. A pediatric oncology patient is admitted with a fever and neutropenia following chemotherapy. What is the appropriate management of neutropenic fever, and how would you address potential complications? Answer: neutropenic fever occurs in patients with a low neutrophil count. Typically, a equals 38 in a neutropenic patient is a medical emergency. Blood cultures. Obtain cultures before starting antibiotics to identify potential pathogens. Physical exam. Conduct a thorough physical examination to identify potential sources of infection, e.g., abscess, pneumonia. Antibiotic therapy. Empiric broad-spectrum antibiotics. Initiate broad-spectrum antibiotics immediately, such as cefepime or meropenem, to cover both gram-positive and gram-negative organisms. Antifungal therapy. If fever persists beyond 72 hours, antifungal agents should be considered. Complication monitoring. Infection control. Isolate the patient to prevent nosocomial infections. Supportive care. Administer IV fluids, monitor vital signs, and provide adequate nutrition to support immune function. Guidelines. According to the Infectious Diseases Society of America (ITA) guidelines, neutropenic fever requires urgent intervention with appropriate antibiotics and supportive care. Close monitoring is essential to detect complications such as septic shock. What are the key signs of post-traumatic stress disorder (PTSD) in children, and how would you approach the assessment and management of a pediatric patient suspected of having PTSD following a traumatic event? Answer: PTSD in children can manifest in a variety of ways and may present differently than in adults. Key signs include re-experiencing the trauma. This can include flashbacks, nightmares, or intrusive thoughts related to the traumatic event. Avoidance behaviors. Children may avoid reminders of the trauma, such as people, places, or activities related to the event. Hyperarousal symptoms. These include difficulty sleeping, irritability, exaggerated startle response, and difficulty concentrating. Emotional symptoms. Feelings of guilt, shame, or detachment from others are common in pediatric PTSD. Assessment and management. Psychosocial assessment. Conduct. A thorough evaluation including a trauma history, family support system, and behavioral changes since the trauma. Psychotherapy. Trauma-focused cognitive behavioral therapy (ET) is the gold standard for treatment of pediatric PTSD. Medication. Antidepressants such as selective serotonin reuptake inhibitors (SRS) may be considered in severe cases, though psychotherapy is typically preferred. A 7-year-old child presents with a first-time generalized tonic-clonic seizure lasting 3 minutes. What is the immediate management approach for this child, and what should be the considerations for ongoing treatment and monitoring? Answer: the immediate management of a child presenting with a first-time generalized tonic-clonic seizure includes initial assessment. When a child experiences a seizure, the primary focus should be on safety. Ensure the child is in a safe position to prevent injury, remove any harmful objects, and place the child on their side if possible to maintain an open airway. Stopping the seizure. If the seizure lasts longer than 5 minutes, it is crucial to intervene. First-line treatment includes administering benzodiazepines like lorazepam or midazolam. If seizures persist, second-line options such as phenytoin or levetiracetam may be considered. Postictal care. After the seizure stops, the child may experience postictal confusion, drowsiness, or agitation. It's essential to monitor the child closely, checking their airway, breathing, and circulation. Conduct. A thorough neurological examination to assess the child's recovery status. Ongoing care. If the seizure is the first episode, further investigations may include EEG or MRI to determine the underlying cause. If the seizures continue or become recurrent, a referral to a pediatric neurologist for ongoing management and possible long-term anticonvulsant therapy is needed. A 10-year-old child presents with a fever, migratory arthritis, and a new heart murmur following a recent sore throat. The child's throat culture was positive for group Streptococcus. What is the most likely diagnosis, and how should this condition be managed? Answer: the most likely diagnosis is acute rheumatic fever (ARF), which is a complication of a throat infection caused by group Streptococcus gas. It typically occurs 2 to 4 weeks after an untreated or inadequately treated streptococcal pharyngitis. Diagnosis: acute rheumatic fever (ARF) is a complication of group streptococcal gas throat infection, often present 2 to 4 weeks after an untreated or inadequately treated strep throat. Common symptoms include fever, migratory arthritis, carditis, erythema marginotum, and Sydenham's chorea. Treatment: the cornerstone of ARF management is the eradication of any remaining streptococcal infection with penicillin or another suitable antibiotic. Anti-inflammatory therapy is also crucial for symptom management, with NSAIDs, aspirin being commonly used for arthritis and carditis. In severe cases, corticosteroids may be used for inflammation control, especially in the presence of significant carditis. Long-term management: to prevent recurrence, long-term prophylaxis with penicillin or azithromycin is recommended for several years or until adulthood, depending on the severity of the initial episode and the degree of heart involvement. Regular follow-up is essential, including echocardiograms to monitor for rheumatic heart disease, a potential long-term complication. A 6-year-old child presents with fever, headache, neck stiffness, and a petechial rash. The child's parents report that the child had a recent history of upper respiratory symptoms. What is the most likely diagnosis, and what is the initial management approach? Answer: the most likely diagnosis is meningococcal meningitis caused by the bacterium Neisseria meningitidis. It is a life-threatening condition that requires prompt diagnosis and treatment. Diagnosis: meningococcal meningitis is a severe bacterial infection caused by Neisseria meningitidis. The clinical presentation includes fever, headache, neck stiffness, and a petechial or purpuric rash. Diagnosis is confirmed by performing a lumbar puncture to obtain cerebrospinal fluid (CSF), which typically shows an elevated white blood cell count, pleocytosis, low glucose, and high protein. Treatment: empiric antibiotic therapy should be started immediately after obtaining cultures. The first-line antibiotics for suspected meningococcal meningitis are ceftriaxone or cefotaxime, which cover most strains of N. meningitidis. Once the specific strain is identified, therapy may be adjusted. Prevention and isolation: meningococcal meningitis is highly contagious, and droplet precautions should be implemented immediately. Prophylactic antibiotics e.g. rifampin or ceftriaxone are recommended for close contacts of the infected individual. Vaccination against N. meningitidis is an important preventive measure and is part of the routine immunization schedule in many countries. A 9-year-old child with a history of asthma presents with wheezing, increased work of breathing, and an oxygen saturation of 88%. The patient is anxious and unable to speak in full sentences. What is the appropriate management of this acute asthma exacerbation? Answer: an acute asthma exacerbation is a medical emergency requiring prompt intervention to relieve bronchospasm and improve oxygenation. Initial assessment: during an acute asthma exacerbation, the child may present with wheezing, dyspnea, tachypnea, and accessory muscle use. The first step is to assess the severity of the attack using clinical signs, oxygen saturation, and possibly peak expiratory flow rates (PEFA). Immediate management: the mainstay of treatment for an acute asthma exacerbation involves bronchodilators. Administer short-acting beta agonists, SABA, like albuterol via nebulizer or metered-dose inhaler (MDI) with a spacer. If there is no improvement, an anticholinergic such as ipratropium bromide may be added. Severe exacerbations: for more severe cases, magnesium sulfate may be administered as it has bronchodilator properties. If the child's condition does not improve with these measures, intubation and mechanical ventilation may be necessary for respiratory failure. Ongoing care: after the acute episode, it is important to review the child's asthma management plan, ensuring proper use of inhalers, controller medications, e.g. inhaled corticosteroids, and trigger avoidance strategies. A 4-year-old patient presents to the emergency room with severe respiratory distress, swelling around the eyes, and hives after eating peanuts. The child has a known allergy to peanuts. What is the initial management step for this patient, and what are the appropriate dosing guidelines for epinephrine in pediatric patients? Answer: the initial management of anaphylaxis involves the administration of epinephrine, which is the first-line treatment for anaphylaxis. Epinephrine acts rapidly to reverse the symptoms by causing vasoconstriction, bronchodilation, and decreasing edema. In pediatric patients, the dosing guidelines for epinephrine are as follows: 0.1 mg of epinephrine administered intramuscularly into the anterolateral thigh. The maximum dose should not exceed 0.3 mg for children weighing more than 30 kilograms, 66 pounds. Epinephrine can be repeated every 5 to 15 minutes if symptoms persist or worsen. Guideline reference: the American Academy of Pediatrics (OP) and the National Institute of Allergy and Infectious Diseases (NIAID) recommend epinephrine as the initial and primary treatment for anaphylaxis. What is the first-line treatment for a 6-year-old patient who presents with urticaria and mild angioedema after being stunned by a bee? The child is stable with no signs of anaphylaxis. Answer: in a pediatric patient with urticaria and mild angioedema without signs of anaphylaxis, the first-line treatment involves antihistamines, H blockers, to alleviate symptoms. Commonly used antihistamines include diphenhydramine, Benadryl, and cetirizine Zyrtec. For moderate symptoms, the dose should be based on the child's weight and age, as recommended by the AP. First-line medication: antihistamines like H blockers, e.g. diphenhydramine 1 divide into 2-3 doses. Adjunctive therapy: if necessary, H blockers, e.g. ranitidine, may be added to help with symptoms. If symptoms persist, consider a short course of corticosteroids like prednisone to reduce inflammation, but steroids are typically reserved for more severe cases. Guideline reference: the World Allergy Organization (WHO) provides guidelines for the treatment of allergic reactions, stating that antihistamines should be the first-line therapy for urticaria and mild angioedema. Sarah, a 3-year-old girl, presents to the emergency room with a fever lasting 5 days, conjunctivitis, a rash on her trunk, and swollen hands and feet. Her mother reports that Sarah has been irritable and has not been eating well. Based on these symptoms, what is the most likely diagnosis and what is the first-line treatment for this condition? Answer: the child's presentation is suggestive of Kawasaki disease, a vasculitis that affects children and can lead to coronary artery aneurysms if not treated promptly. The diagnostic criteria for Kawasaki disease include fever lasting 5 or more days along with at least 4 of the following symptoms: bilateral conjunctivitis without exudate, oral mucosal changes such as red, cracked lips or strawberry tongue, polymorphous, rash, extremity changes such as swelling or erythema of the hands and feet, cervical lymphadenopathy. The first-line treatment for Kawasaki disease is intravenous immunoglobulin, IVIG, typically administered a dose of 2 grams over 10 to 12 hours. This therapy helps to reduce the risk of coronary artery complications. Additionally, aspirin is used to reduce inflammation and prevent thrombosis. IVIG, 2 grams Gasprin, 8010 a day, divided into 4 doses until the fever subsides. A 7-year-old patient experiences anaphylaxis after consuming a food item containing shellfish which he is allergic to. Describe the immunologic mechanisms that lead to anaphylaxis in this scenario. Answer: Anaphylaxis is triggered by an Ig-mediated immune response to an allergen such as shellfish. When a sensitized individual consumes an allergen, their Ig antibodies specific to that allergen bind to mast cells and basophils. Upon subsequent exposure to the allergen cross-links the Ig on the mast cells and basophils, triggering the release of a variety of mediators, including histamine, leukotrienes, and prostaglandins. These mediators cause vasodilation, smooth muscle contraction, increased vascular permeability, and airway constriction, leading to the clinical manifestations of anaphylaxis, such as respiratory distress due to bronchoconstriction, hypotension, due to vasodilation, edema, and hives, due to increased vascular permeability. Guideline reference: The National Institute of Allergy and Infectious Diseases (NIAID) outlines the immune mechanisms involved in anaphylaxis and emphasizes the importance of prompt epinephrine administration. 5-year-old patient presents with a widespread rash, mucosal ulcerations, and fever after starting a new antibiotic. What are the critical signs to distinguish between Stevens-Johnson syndrome (SJS) and toxic epidermal necrolysis (TEN), and what is the recommended management for these conditions? Answer: SJS and TE are severe life-threatening drug reactions, typically triggered by medications such as antibiotics or anticonvulsants. The critical differences between the two conditions are based on the extent of skin involvement. SJS, characterized by less than 10% of the body's surface area BSA detachment. TEN, characterized by more than 30% BSA detachment. Both conditions present with fever, skin erythema, and blistering, but in T, the skin detachment is more extensive and involves deeper layers of the dermis. Mucosal involvement, oral, ocular, and genital ulcers is common in both. The first step in management is the immediate discontinuation of the offending drug. Supportive care in an intensive care unit or burn unit may be necessary, including fluid resuscitation, wound care, and nutritional support. Systemic corticosteroids and immunoglobulins may be used in some cases. Guideline reference: The American Academy of Dermatology (OD) provides guidelines for the recognition and management of SJS and TE, and emphasizing drug withdrawal and supportive care. A 9-year-old presents with joint pain and swelling in both knees and difficulty walking. She also has a fever and a recent history of a viral infection. What is the most likely diagnosis, and how should this condition be managed in the emergency setting? Answer: This child likely has juvenile arthritis here, a chronic inflammatory condition that can present in the emergency setting with joint pain, swelling, and fever. JA can occur after viral infection or be triggered by other environmental factors. The most common form of juvenile arthritis is oligoarticular JA, which typically affects 4 or fewer joints. The initial management involves the use of NSAIDs, e.g., ibuprofen or naproxen to reduce inflammation and pain. If there are signs of systemic involvement, such as persistent fever, corticosteroids, e.g., prednisone may be indicated to control inflammation. In severe or resistant cases, biologic agents such as TNF inhibitors, e.g., etanercept, may be considered. Guideline reference: The American College of Rheumatology (ACA) provides guidelines on the management of juvenile arthritis, including pharmacologic treatment options. A 2-year-old child is brought to the ER after ingesting an entire bottle of diphenhydramine, Benadryl. The child is alert but has dilated pupils, dry mouth, and tachycardia. What are the expected effects of diphenhydramine overdose, and what is the management approach? Answer: Diphenhydramine, Benadryl, is an H and a histamine that, when overdosed, can lead to anticholinergic toxicity characterized by dilated pupils, mydriasis, dry mouth, and skin, tachycardia, urinary retention, delirium, or agitation. Management of antihistamine overdose includes activated charcoal if the ingestion was recent, within 1-2 hours. Supportive care: Ensure the child is hydrated and monitor for signs of cardiovascular instability. Benzodiazepines may be used for severe agitation. Physostigmine may be considered in severe cases, as it is a reversible acetylcholinesterase inhibitor that can counteract the toxic effects of the overdose. Guideline reference: The AAP provides management guidelines for poisoning and overdose, including the use of activated charcoal and symptomatic treatment for anticholinergic toxicity. A 5-year-old with a history of eczema presents with a red, swollen, and tender lesion on her right cheek. The lesion is filled with pus and she has a fever. What is the most likely diagnosis, and what is the recommended treatment approach? Answer: The patient likely has cellulitis, a bacterial skin infection that can result from a break in the skin barrier, such as eczema. The most common organisms responsible for cellulitis are Staphylococcus aureus, including MRSA, and Streptococcus pyogenes. Treatment involves empiric antibiotic therapy, Oral antibiotics such as cephalexin or clindamycin for non-MRSA infections and trimethoprim sulfamethoxazole or clindamycin for MRSA infections. Warm compressors for pain relief. Fever management with antipyretics like acetaminophen or ibuprofen. Guideline reference. The IDSA, Infectious Diseases Society of America, provides guidelines for the treatment of skin infections in children, recommending appropriate antibiotics based on local resistance patterns. A 12-year-old girl with a history of systemic lupus erythematosus (SLE) presents with worsening swelling in her legs, high blood pressure, and dark-colored urine. What is the most likely cause of her symptoms, and how should she be managed? Answer: this patient's symptoms are indicative of lupus nephritis, an inflammation of the kidneys caused by SLE. Lupus nephritis can present with edema, hypertension, and hematuria due to immune-mediated damage to the glomeruli. Management includes immunosuppressive therapy, high-dose corticosteroids, e.g. prednisone, and cytotoxic agents, e.g. cyclophosphamide or mycophenolate mofetil, blood pressure control, use of ACE inhibitors or ARBs to manage hypertension and reduce kidney damage, diuretics for fluid management if necessary. Guideline reference. The American College of Rheumatology (ACA) provides guidelines for the management of lupus nephritis in pediatric patients. A 4-year-old child with a history of asthma presents to the emergency department with severe wheezing, shortness of breath, and increased work of breathing. The child is using accessory muscles and has a prolonged expiratory phase. What is the most appropriate initial treatment for this acute asthma exacerbation? Answer: this child is presenting with an acute asthma exacerbation likely triggered by an allergen or viral infection. Initial treatment should focus on rapidly relieving bronchoconstriction and reducing airway inflammation. The recommended approach includes inhaled bronchodilators, e.g. albuterol or salbutamol, administered via nebulizer or metered-dose inhaler (MDI) with a spacer. These provide rapid relief by relaxing the smooth muscles of the airways. Systemic corticosteroids, e.g. prednisone or methylprednisolone, to reduce inflammation. Oxygen therapy. If the patient is hypoxic, e.g. oxygen saturation 92%, administer supplemental oxygen to maintain appropriate saturation levels. Reassessment. After initial treatment, reassess the patient's response. If symptoms persist or worsen, additional doses of bronchodilators or even magnesium sulfate as a bronchodilator may be considered. Guideline reference. The Global Initiative for Asthma (GINA) guidelines provide detailed management strategies for acute asthma exacerbations in children, emphasizing the use of bronchodilators and corticosteroids.